Welcome to our session today. It's called From Seizures to Storms, Understanding the Nuances of Epilepsy, Neurostorms, and Movement Disorders in GRI. We're going to have 3 speakers today, but first I'd like to let you guys know that the bags with the different things in them are ready, so you can pick them up if you are interested in picking up the GRI bags. They're at registration, so you can pick them up today, or if you would like, tomorrow on the last day. But they are ready now for each of you, for each of the attendees. So today we're going to be talking about neurostorms. It's a very popular and very interesting topic. And we have 2 clinicians, and we have a mom, Bernie Pivot Mullen, and she's going to talk about her son. That's where we're going to start off to give you kind of the first person experience of it. And Dr. Park is going to ask her some questions about neurostorms. And then Dr. Park will do her presentation, and Dr. Kaufman will be the third one. Okay.
All right, great. So, Bernie, why don't you just start telling us a little bit about your son, his name, and who he is, and what he's doing, and that type of thing. Oh, I thought
Oh, there it goes. Hi, I'm Bernie, and my son's name is Tristan. Tristan will be 30 in November. He predates Grin.
Can you hold it?
He predates Grin. And it's been a rather long adventure. Initially, he had everything under the sun, except what he actually had. He presented with seizure at 5.5 months, and within 30 days had lost 1/3 of his body weight and was on a downward slide to not being here by his first birthday. So Tristan didn't care what they said, and he's here. He has had 9 different types of seizures over 30 years. He's gone from having 12 to 15 a day, to having 2 or 3 a month, to just recently not having one since February 6th.
Wonderful.
And like many other things having to do with Tristan, we have no clue why. He was on Namenda for 10 years. Initially, we saw great improvement in his cognition and recognition and in his ability to engage. And then he plateaued. And this year, 2024 rather, when we started to do a medication review, which we do periodically, we decided that we were going to try removing Namenda from his 29 pills a day and see what happened. And lo and behold, nothing happened.
Okay.
Until he was all off of it. And suddenly he's smiling again. He's engaging a little more on a regular basis. He seems more focused. The same things that happened when he went on the drug are now happening when he came off the drug.
Interesting.
So he has seizure disorder still. He has GI reflux, he has cortical vision impairment, he has reactive airway disorder, he has CP, he's got the whole gamut.
Mm-hmm.
But he still seems to enjoy what he's doing. He goes to a day program in Downingtown, which is near our home, and he engages with other individuals with disabilities, and he goes food shopping and to the movies and to art museums and all kinds of things.
Great.
He has gone everywhere with us every day of his life, and he can be quite sassy.
Sounds like it. That's a common trait I'm hearing. Has he ever had autonomic issues or issues with his peripheral nervous system?
Yeah, Tristan had more autostorms at a very young age. He used to cry incessantly for long periods of time. That sort of went away when he was 7 or 8 on the consistent basis, but he would every once in a while have one. They seem to be related. He has them when we have big storms. When there are severe changes in barometric pressure, he can suddenly go into a session of not being able to get comfortable, and total movement and irritation. Tristan cried incessantly until he was about 4 years old, and then he never made a sound until he was about 25 years old. And he sat up in bed one night, and Sonny heard him talking to her. And we had never heard him speak for almost 20 years. Now, he no longer sits up. He lost some abilities. He had a seizure about 8 years ago and lost a good bit of his peripheral vision on his right side. He still occasionally has neurostorms, but those are infrequent. He also hasn't had one of those since February.
Great.
So all in all, Tristan's life is pretty decent.
All right. Well, thanks so much for sharing your story. Maybe we'll get started, do you think? Okay. Awesome. So this was a pretty big task. I'm, of course, only going to tackle part of the task, and I'm going to leave the rest of it to Dr. Kaufman. But I wanted to talk a little bit about, and first of all, I'll introduce myself. I'm Kristen Park. I'm one of the neurologists and epilepsy docs at Children's Hospital of Colorado, where there is a clinical GRI center, and we see some patients. And I'm also involved in the Simon's Registry for GRI disorders. So I'm going to talk about seizures and a little bit about some data from the registry that I wasn't sure if Dr. Kaufman would have access to, so a little bit about the incidence of movement disorders and other autonomic features in the registry, some of the challenges and distinguishing between some of those things, and then I had some videos that we will try to play. I downloaded them from YouTube, so I don't know, maybe there's going to be an ad or we might have to skip one, but we'll see how it goes. So if we could take the next slide. All right, so I think the first thing to do before we dive into who has epilepsy and how many seizure types do they have and what all this kind of stuff is to talk about what is actually epilepsy. So epilepsy, if we talk about these different definitions, so epilepsy is people who have seizures, right? So then we have to say, well, what is a seizure? So a seizure is some sort of sudden involuntary, so not controlled by the person, usually time limited, typically 1 to 5 minutes, alteration in some sort of behavior or activity, consciousness, and it is accompanied by an abnormal EEG that indicates that that behavior, that problem is being caused by overactive neurons within the brain, okay? So we now have somebody who has these symptoms that last for a few minutes. We think they've had a seizure. How do we know if they then have epilepsy? So epilepsy used to be defined as 2 or more unprovoked seizures separated by more than 24 hours. And the significance of that unprovoked in italics is that anybody can have a seizure, right? If you had meningitis or you got allergic reaction to a medicine you were given or you were hit in the head with a baseball bat or in a car accident, anybody can have a seizure. Those seizures would be considered provoked because something happened to the body, to the brain that caused that seizure to occur. Somebody with epilepsy can have seizures for whatever reason. They can have it because it's Tuesday, they can have it because they missed their medicine, they can have it because they had a poor night of sleep, whatever, but they just can generate those seizures without any real big, significant provoking cause, okay? And then that could happen again in the period of 24 hours, but that could be, an illness or something else that might never happen again. Once someone has repetitive seizures, then we say, okay, well, that is a clue that the brain can go on to continue to have seizures, and we think that that should be treated, and that meets a different set of criteria. recently, the ILAE, the International League Against Epilepsy, kind of changed the definition of epilepsy a little bit, and they now say that it's a disease of the brain. So I think it used to be called a disorder, and there's some kind of political and economic and medical distinctions between being a disorder and a disease. So they changed it to disease, and then it's of the brain, and you can either have that same set of symptoms that we talked about, or you can have an unprovoked seizure and a high probability that you're going to have another seizure. And that high probability might come from the fact that you have a neurogenetic diagnosis. It might come from the fact that your EEG is abnormal, or it could come from the fact that you have a probable epilepsy syndrome. And we'll talk about what an epilepsy syndrome is in a little bit. So if you have that predisposition, then we could go ahead and treat you right then, because we know that you're probably going to have more seizures and that you probably meet the criteria for having epilepsy. This was done a lot for adults who would want to go back to driving or their job. They'd want to have some answers. And so we said, well, we can treat you now based on this because we know that it's really highly likely that you're going to go on and have more seizures. Next slide. So these are the types of seizures that there are. And the kind of two big buckets are seizures that are generalized, that start from the whole brain at the same time, and seizures that are focal, something that starts from one part of the brain and may or may not spread to another part of the brain. Then there's that category on the side, which is unknown, meaning maybe somebody didn't see the start of the seizure, they're not really sure, or for epileptic spasms, we don't really understand how the seizure actually works, and so we're not sure if it's a focal or generalized seizure. But in general, most seizures will fall into one or both of one of those categories. And this is the paper that cites that. And so you see a lot of different types of seizures. People often tend to have seizures within the same category. So there are people who have multiple types of generalized seizures, and then focal seizures may or may not spread to become a bigger convulsion. Next slide. So when we talk about seizures, we like to talk about something called semiology, and this is what helps us to figure out whether the seizure is a focal seizure or a generalized seizures. And so we talk about clonic movements, so jerking movements, tonic movements, stiffening movements. We might talk about things that are not motor symptoms, like someone who sees something or feels something, somebody who stops doing what they're doing. And the other words that you might hear are ictal, which is during the seizure, pre-ictal, or post-ictal, meaning before or after the seizure. And all of this information, I think, is very important when talking to your doctors to say, this is what I observed, this is what happened during the course of events, and that can help the doctor to tell you, okay, I think this is a generalized seizure, along with usually the EEG, or I think this is a focal seizure. Next slide. So when we talk about a syndrome is actually kind of a set of symptoms that usually travel together. And when we think about epilepsy syndromes in specific, we think about when did they start, what kind of seizures are associated with them, what does the EEG look like, how do they respond to treatment, and what is the cause of those seizures. And there are probably 30 or more syndromes that are recognized, but we tend to now break them down into this kind of schematic where we think about what is the cause. Did somebody have an infection? Did somebody have a brain malformation? Or do they have a genetic etiology to their epilepsy? And so we kind of put all this together to come up with a syndrome. Next slide. And these are the syndromes that, again, are recognized by the International League Against Epilepsy. And so I think it's important for people to understand that you can have a syndrome diagnosis as well as having a genetic diagnosis. So the genetic diagnosis might be GRIN1, GRIN2A, GRIA, but you might have another syndromic diagnosis for epilepsy like Lennox-Gastaut syndrome or West syndrome in the case of epileptic spasms, or it's the ESES or DEESWAS, which is the epileptic status epilepticus in sleep, or developmental and epileptic encephalopathy with spike wave activation in sleep, DEE-SWAS, because we like to rename everything every 4 to 5 years and make it really confusing. Also referred to as Landau-Kleffner syndrome. So it's possible to have a syndrome as well as a genetic diagnosis. They're not exclusive. One doesn't replace the other. They're just a different way of saying some of the same things that you observe. Next slide. So why do we, how do we make the diagnosis of epilepsy? The biggest thing is what happened, the history. So talking to the neurologist and saying, this is what I saw. This was the first thing that happened, the next thing that happened, and then, you know, kind of what did other people see? What did the person experience? When did this happen? How often does it happen? All of those features, I think, help us make the diagnosis. And then the next best thing is to do an EEG. So, you know, EEG is not a perfect test. You know, it can only pick up abnormalities at a certain point in time. It doesn't, if you don't catch the event, you may not know. People with neurogenetic disorders also have a higher incidence of abnormal EEGs, but that doesn't necessarily mean that they had a seizure. It could just mean that their brain functions a little bit differently. So the best thing is that you have to pair those things together. And sometimes that happens with a prolonged study where someone comes into the monitoring unit, has a seizure, we can see what kind of seizure it is, and then we can help them to make better treatment decisions. Next slide. So I think a big question that comes up frequently is how do you decide when something is a seizure and when it's something else, when it's a storm, when it's a movement disorder. And so these are some kind of distinguishing features between epilepsy and movement disorders. Movement disorders are often more constant, last for a longer period of time. Typically, you know, they don't happen in sleep, whereas epilepsy often has seizures that are triggered from sleep. Most seizures you can see on an EEG, whereas a movement disorder is not going to show up on an EEG. And then seizures typically have a very stereotyped pattern. Each time they happen, the first thing happens first, the second thing happens second, they kind of build, and then they peter out and stop, and the person may have a postictal period. So it kind of has the same storyline every time it occurs, whereas a movement disorder can be highly variable and happen in lots of different ways throughout time. Next slide. So these were some videos that, again, we're going to see how they do, but these are some things that are often confused for seizures. I put some seizures on here just to warn you. So we're going to see some hard things, but we're just going to talk through them. Okay, so this is the first video. Okay, so you can see he's pushing this person's foot and it's twitching. And it's twitching really fast, right? And it's twitching in the same way, front and back, front and back, front and back, right? Moving, oscillating in kind of the same manner. And then he's going to put the foot down and it stops. Right? Okay, so that is clonus, and we have some nice ads here. So that is clonus. That is a reflex that your body has, especially when the tone is very high, that if you flex that and you change the length of that tendon, it sends a message to the brain, and it causes that muscle to fire and fire and fire over and over and over again. When you put the body part down and you relax that tendon, it goes away, okay?
Test mom is right here.
Having a convulsion.
You're gonna be okay, sweet.
Here, maybe that jerking is different. So it has a fast and a slow component. Fast, slow, right? And it happens a lot slower. So it's usually for clonic jerking, for a generalized tonic-clonic seizure, it's about 3 times per second that the person is able to jerk and relax, as opposed to clonus, which is much, much faster, right? And this is not going to be affected by any positioning or any other change. It's going to run its course, and it's not going to be, any different. Often the body will extend this way. So when there's a tonic-clonic seizure, tonic is the first phase, stiffening, and then clonic is the second phase, the jerking. So it happens in that way every time. Stiff, and then jerk with a fast phase and a slow relaxation. Okay.
She's okay.
Next video. Okay, so this is a very particular type of seizure. Okay. Okay, so what you're seeing here is epileptic spasms or infantile spasms, right? Arms extending, stiffening, and then relaxing. It happens in a cluster, frequently, sometimes upon awakening or going to sleep. Very particular kind of seizure that is associated with a very severe background EEG abnormality. Go on to the next one. This is a focal seizure, right? So it started off with head turn to one direction, some twitching, eyes deviate to one direction, focal seizure. This is some data from our registry about the incidence of epilepsy. So this is only U.S. cases, and this is when I look at our N is about 108. If we just look at pathogenic or likely pathogenic variants, missense is of course most common, and so the total incidence of epilepsy is about 68 of those patients. 63% would have epilepsy of all of the diagnoses that we see there on the left. Next slide. Okay, and then we looked a little bit about EEG data, and we had about 70 patients who had gotten an EEG. Many of them were initially normal, but if we went on and got a subsequent EEG, sometimes they became abnormal, and that is a very common thing to see. There are studies that look at the incidence of EEG abnormalities in people with epilepsy, and often the first study is normal. Peaks about 4, so doing more than 4 probably not going to get you any further, but sometimes that can change over time, right? A baby can have a normal EEG, but then when seizures start at 4 or 5 years of age, that EEG can be abnormal. Most patients had 1 to 2 seizure types, and the most common was generalized tonic-clonic seizures. There were about 6 people who reported infantile spasms, that clustering seizure that we saw, but no patients reported that their EEG showed hypsarrhythmia. And that is possible to have the type of seizure without the hypsarrhythmia. Frequencies were variable, and many of the seizures had some autonomic features to them. Next slide. There was a big spread of people taking different types of seizure medications, none of which kind of really stood out as being the most effective or most common, although I think clobazam there is the big one, the big line. Next slide. This was our data on movement disorders and dysautonomia. So storms were reported in 24 patients. In clinic, I've only seen one GRIN 1 patient who reported this symptom to me, but many others reported other autonomic dysfunction to me. So not being able to feel pain or temperature as the same as other children, problems regulating their own internal body temperature, and then other vital sign abnormalities like bradycardia or flushing or elevated blood pressure. Next. So finally, what I'll say is that epilepsy is a really broad diagnosis. As you saw, there's lots of different types of seizures, lots of different types of syndromes, and symptoms vary between patients. So there are not very many patterns that we know yet. I'd also say I tried to assemble this data from our registry, and we had a lot of blank answers. So if you're a member, please go back and complete things. Leaving it blank is not the same as saying no. The system doesn't recognize it the same, and I don't know what you mean, right? There's a lot of overlap between epilepsy, movement disorders, and storms, and I'd say, the most powerful tool is in your pocket, your smartphone. A video, if a picture is worth 1,000 words, a video is worth 1,000,000 words, okay? And then also keeping a diary so that you can talk to your doctor about what the triggers are, what things look like, help them figure out what's going on with your child. Okay, thanks so much.
Okay. Can folks hear me all right? Okay. Oh, sure. Okay, so I'm here to talk about those things that aren't seizures that you're like, well, what is it then? Okay, I have no financial relationships. I have no money. Okay. I work at an academic medical center. Okay, so the key points to understand, we're going to talk about the autonomic nervous system, what parts of the brain regulate it, what's the phenomenology of autonomic dysfunction. So your autonomic nervous system is responsible for all the automatic stuff that the brain does, okay? Heart rate, respiration, temperature, moving things through your gut, peeing and pooping, sweating, skin vascular tones. What do I mean by skin vascular tone? Whether your arms and hands are warm and red or cold and blue, okay? Arousal state, so how awake or alert you are. Sleep-wake cycles and pain response. Okay. So the autonomic nervous system has three branches. Okay? There's the enteric nervous system, which is basically esophagus to the rectum. Okay? What moves things through your gut. There's the sympathetic nervous system, which is your fight, flight, or freeze phenomenon. And then your parasympathetic, which is your rest and digest. Okay? So when you think about these two, these are the yin and yang of the human body. Okay? Is there a, yes, there is, good. So your sympathetic nervous system over here on the right, everything is red. This amps up the system. When this gets amped up, your pupils get big, you start to produce a lot of saliva, you sweat more, you breathe faster, your heart rate goes up. And the parasympathetic does the exact opposite. Okay? So they typically live in balance. Okay? When we think about the regions of brain that regulate autonomic output, we think about the hypothalamus. So as a non-cortical based neurologist, right, I take care of movement disorders, so I don't work on the surface of the brain for the most part, I work deep. The hypothalamus is the control center for autonomic function. Hunger, thirst, sleep-wake cycles, temperature, heart rate, blood pressure, and blood vessel tone. Okay? And then pain, sweating and drooling, and hormone release. Other parts of the brain that regulate autonomic nervous system and have a role in autonomic nervous system is the substantia nigra, literally translated from Latin, substance black, okay, because if you look at the basal ganglia in the brain, it's actually black. This is involved in, same thing, autonomic nervous system, but also reward and motor control. Best example that almost everybody in the audience knows, if somebody has not enough dopamine in their body, they have Parkinson's disease. So if you think about the movement, character, and quality of someone with Parkinson, their movements are slow, their speech is quiet, and their autonomic nervous system doesn't work. Then we move on to the part of the brain where serotonin lives. Serotonin is the other big neurotransmitter in the brain that's responsible for pain, mood, vomiting, and blood vessel tone. Then getting all the way down to the bottom of the brain, the medulla, which is right above the top of the spinal cord, heart rate, breathing, sneezing, and vomiting. Okay? So, as I said earlier, these systems usually live in balance. When the balance gets disrupted, problems happen. Okay? So, paper a few years ago by myself, Dr. Ann Berg, and Dr. Deborah Gabler-Spira looked at the rate of autonomic dysfunction in patients with DEEs, and I can't remember if any of the GRI or GRIN disorders were included. What we did is we surveyed patients using an established autonomic screening tool that was developed for patients who have a congenital autonomic neuropathy. And we looked at 18 symptoms in 6 different domains and found that 81% of patients who reported and then had autonomic dysfunction, and when you look at impairment in at least one functional domain, 90% of this patient population had autonomic dysfunction, just as Dr. Park had mentioned earlier. They may not all have storming episodes, but most of them have problems with at least one part of regulating the autonomic nervous system. So then we're going to talk about what happens when the balance gets severely disrupted. Okay? So if you have a problem here where your autonomic nervous system, specifically your sympathetic nervous system, gets overly active and your parasympathetic system can't keep up, you get autonomic storms, also known as neurostorms. The current most accepted, most published name in the medical literature for this is what's called paroxysmal, sudden onset, sympathetic hyperactivity, okay? So your sympathetic nervous system, your fight, flight, or freeze system is all of a sudden super hyperactive, okay? We now know, based on this paper here, that there are criteria to diagnose this. However, they've still only been used in patients after brain injury. There are some emerging pediatric tools to look at this, and people are starting to realize that this doesn't just happen in patients with traumatic brain injury. Okay. So what happens with this is that in many patients, it can look like a seizure. It can look like an episode of agitation. But what happens is you get increased body temperature, heart rate, you can get flushed, you can drool, you can be profoundly agitated, and you can have abnormal movement called dystonia. Okay. Often mistaken for seizure, but as Dr. Park said, you get an EEG during an event, EEG doesn't show any change in EEG. And then you're like, well, what the heck is it? Okay. As Dr. Park said earlier, seizures aren't typically hours long. These events can be hours and hours and hours at a time, and they can be profound and they can be severe. So this is an example of a patient who has a different developmental and epileptic disorder. This is a young girl who has an SCN2A disorder. And this is a video of her events. Okay, so you can see she's red. You can hear her screaming. Look at the position of her left hand and look at her left toes. Okay, they're curled and her foot is distorted downward. She's having a severe dystonic event as part of her PSH episode. The force of this episode, not this particular episode, but the force that this little girl was able to generate with these PSH episodes with accompanying dystonia was so severe that she broke her own femur. And that's how I met her. Because my epilepsy colleague, Dr. Errol Hall, who trained at Denver with Dr. Park, was on our inpatient service, brought this little girl in because she thought she was having worsening seizure, hooked her up to EEG, saw that the EEG was unremarkable, diagnosed the broken femur and said, I think you've got a movement disorder. You need to see Dr. Kaufman. So I came up and I met her, and sure enough, this was severe dystonia along with paroxysmal sympathetic hyperactivity in this little girl. Okay. So these are things that PSH episodes are not things you can stop, right? You can't give a medication and abort this. You have to prevent this, okay? When you think about this, you have to think about the things that can trigger this, okay? Cooling the room down, right? Because overheating will do this. Decrease the light, decrease the sound. Fix the sleep, okay? So one of the biggest problems, one of the biggest drivers of this, because it comes from the hypothalamus. The hypothalamus is where your circadian rhythm lives for sleep-wake cycles. If your child is not sleeping, this puts a bigger risk for this to happen, okay? Bowel and bladder control. If you've got a big distended bladder or if you're constipated, that increases the risk for this to happen. Okay. And evaluate for pain. So the necessary evil that has become video visits since the COVID pandemic really limits at times the ability to look for pain generators, right? Whenever I see somebody who's having stuff like this, I say, you know what, I cannot assess this by video. I need to get you in the office and examine from head to toe and look at things like, what do the muscles feel like? What's the skin look like? Is there anything that is a source of irritation that could cause this to occur, okay? So you have to be a very, very good general doctor in addition to being a very, very good neurologist to look at these kind of things, okay? So, like many things in the world of pediatric disease and pediatric rare disease, this isn't studied well yet, okay? We use medications to prevent PSH or autonomic storming that decrease the output of the autonomic nervous system, okay? So we use medications that decrease dopamine release, and we use medications that decrease norepinephrine release, also known as noradrenaline, okay? If somebody has a source of pain driving their PSH, we use non-opioid medications to treat the pain. And then if they've got dystonia, and oftentimes in my world, I sit and watch videos obsessively, and it's, what did I see start first? Did I see a dystonic movement start first, and did that pain from the dystonia trigger the PSH episode, or was the PSH episode going on and then we got dystonic because we were so irritated, so agitated, okay? Then one might wonder, why patients with GRI disorders may have this happen. So we talked earlier about the hypothalamus, and is there any evidence that glutamate receptors affect hypothalamus function whenever you modulate them or mutate them? And it turns out that there's a lot of evidence that shows if you change the way NMDA receptors work, you get a lot of problem with the way your hypothalamus works. So poor growth, poor sleep, autonomic dysfunction, appetite problems, pain. Yep. So what about the other symptoms in GRI disorders? Keith knows that I've stolen this and used it for a couple years now. It's a Keith network. It's okay, right? One Keith to another, we're good with this, okay? So as a neurologist and as a movement disorder doctor, I think about the brain as a system, okay? My background is in systems neuroscience, so how area A compares to area B connects to area C and vice versa. So when we think about a group of conditions called the pediatric neurotransmitter disorders, they have the following symptoms. Okay? Low muscle tone, seizures, problems with autonomic regulation, GI dysfunction, movement disorders, oculogyrate crisis, which Dr. Park actually had on near the bottom of her slide in terms of movement disorder symptoms, sleep disturbances, irritability, and developmental delay. Okay?
3 minutes.
Yep. So when we think about the different neurotransmitters involved, we talked about what dopamine does, and we talked about norepinephrine, and we talked about epinephrine, which now pupils large, autonomic control. We talked about serotonin, okay? So why might GRI disorders resemble neurotransmitter disorders? Because my part of the brain is the basal ganglia here. These are the internal brakes of the brain. They keep you from moving when you're not supposed to, okay? This is the chemistry of the basal ganglia, the chemistry of our brakes, so to speak. And all these little abbreviations are the different neurotransmitters, okay? So when we think about different neurotransmitter disorders like Parkinson or Huntington or another rare genetic disorder, SSADH deficiency, we know that the problem is in these different neurotransmitter systems. Now, in the GRI disorders, what happens to the neurotransmitters in the basal ganglia when you disrupt glutamate system-wide? Same system, same geography. What's the chemistry? What's the downstream effect? Okay, so in closing, autonomic nervous system must work in a balanced way to effectively work. When you disrupt it, it affects the whole human. PSH, as we talked about, under-recognized. Anomalies of the hypothalamus result from dysfunction in glutamate receptors, and other neurotransmitter systems may be a downstream effect of GRI mutations. And that's time.
I just wanted to know if you would have the
think so. I think they're supposed to be being captured.
So the question was, will the slides be available? The answer is yes.
Okay.
Is mine on? Oh, yeah. I was wondering if, in both of your experience treating folks with GRI disorders, if there's a sort of typical age of onset of PSH type symptoms or other, aspects of these movement challenges you've been describing, or if it sort of runs the gamut across the age spectrum.
So great question. In the patients that I've treated with any of these disorders, the SCN2A, GRI disorders, it is all over the age range whenever you develop autonomic dysfunction or movement disorders. I can speak in terms of the SCN2A population. If you have a gain of function, it tends to be much earlier in life when loss of function is later, sort of second decade. But I don't know enough about gain and loss with the GRI disorders yet, because the numbers aren't as big, to be able to speak to that.
Hello. My son has GRN2A, ES, and we were told that it's possible he might grow out of it around age 15. Is that?
Yeah, so I think this is another under-recognized and undertreated diagnosis. So we've just kind of associated it with GRI disorders in the last, 5 to 10 years. Mostly it derives from dysfunction of the thalamus. So another part of the brain, a deep part of the brain that communicates with the cortex and kind of coordinates sleep. And so we've seen it in patients who have strokes with injury to the thalamus. We've seen it with other types of epilepsy, but it doesn't get as much attention as we need. So I think the previous literature from a long time ago kind of had it resolving in adolescence. At least the EEG abnormality is going away. But I think the actual natural history of that diagnosis specific to GRIN disorders is not as well known. So I don't know that, that we can say, what will happen.
I've got a question from the online audience. So this is for Dr. Kaufman. This person said that what you talked about matches exactly with what his son experiences. And so he's asking for some of the prevention medicines like sleep and bowel and bladder control. Do you recommend addressing those with narrowly targeted measures like sleeping pills and laxatives?
Okay, so when it comes to looking at the triggers that can incite an autonomic storm, I go as natural as possible, right? So when it comes to sleep and sleep-wake cycle regulation, sleep environment is the critical most important thing, right? Is the room nice and cool? Is the room appropriately dark? Are there minimal to no distractions well before we get into the world of using any medications for sleep? Because of the fact that we don't have good data, either short-term or long-term, on the safety of any medications for sleep in children and teens. When it comes to GI, it goes back to the old school approach of fluids and fiber, right? So the challenge with fiber is if you're on a pure liquid diet from a standpoint of being gastrostomy tube fed or J tube fed, it's really hard to get all the natural fiber that you get if you eat more of a plant-based diet. So a lot of my patients, in addition to what we do in neurology, many of my patients have a good gastroenterologist that they see to try to help with the GI symptoms to make sure that all is moving well that way.
I had a general question for a kind of clinical question. In terms of redressing the balance in the autonomic nervous system, have you considered using cholinergic agonists as a way of potentially redressing the balance, like bethanacol or pilocarpine, I guess that's normally eye drops, isn't it? But is there anything like that that could be potentially thought of as a potential preventative measure?
What class of medications again?
Bethana is like a cholinergic, muscarinic type agonist type drug.
Okay, so interestingly, when we think about the problems with autonomic instability here with the adrenergic surges, I don't know anyone who's tried to compensate by using something like Mestinon or any of the agents that would sort of better increase the activity of the parasympathetic system. So no, not to my knowledge has anyone tried that.
Well, we can hear you, but online can't hear you. But up here?
Okay.
Okay. Our son is 17, did not have a sleep disorder at all until he hit puberty. Then we put him on trazodone, and now it seems like he's having more storms. Is there any relationship to possibly being on trazodone, if that's leading to these storms?
So when it comes to changes in sleep and biology in the teenage years, when you look at what happens to the teenage brain in terms of natural activation and changes of the brain goes through some of the most dramatic electrical changes that it does in entire human life between 13 and 25, right? So the system completely changes in terms of what's active, what's most active. So in listening to Bernie's story earlier today about Tristan and his great response early in life to Namenda and then side effects from it later on, that alone could be part of it. It could just be the changing biology of his brain in terms of the teenage years as opposed to the side effect of trazodone. Because if he's been on that medication for a number of years and then the storm started, then it's a much different story of he started trazodone and 1 week later the storm started. And I think...
Yeah, I just wanted to add the autonomic, the Neurostorms. Tristan broke his leg during a comparatively very mild seizure that was sudden onset, and sudden onset so fast that his tibia snapped. So it does happen.
Hello. So my son has GRI 3 and he has epilepsy. He has both focal and generalized seizures. So I'm just wanting to know, because right now we're just trying different medications and they're not working. Are there like specific kind that you think will work best for the GRI 3 gene?
I don't know if we know specifically which works best, but I do know that there are some patients trying Fycompa, which is an AMPA receptor antagonist. So I think that would depend on what kind of GRIA variation he had. I think, as I showed, Onfi had a lot of patients taking it, and I do think it's an exceptionally effective anti-seizure medicine. So clobazam is the United States name. But there are unfortunately a fair number of patients with GRIA disorders who have treatment-resistant epilepsy, and that means that a lot of the medicines don't work. We do have kids who are using adjunctive therapies like dietary therapy or neuromodulation devices as well. So I think it's really a matter of continuing to try things.
Okay, thank you.